Hi, my name is Stuart Winkler, and I'm a GYN Oncology Fellow at Walter Reed National Military Medical Center. I'm also an assistant professor in the departments of obstetrics and gynecology at USUHS. Today I'm going to be giving a talk on gynecologic hereditary cancer syndromes. This talk is primarily aimed at residents, OBGYN residents, and medical students, and hopefully can be helpful for those whose academics are being suspended during the COVID crisis. My objectives for this talk, so I want you to appreciate the role of oncogenes and tumor suppressor genes in gynecologic cancer, to define diagnosis and features of common gynecologic hereditary cancer syndromes, and to understand the implications of genetic mutations on treatment options and patient outcomes, and then to recognize the role of genetic counseling in the care of the patient and family with these syndromes. I'd just like to start off with a little story, a historical vignette, to give us a sense of how we got to the point where we have our current understanding of these syndromes. Really, for 2,500 years, all the way back to the Greek historian Herodotus, we've understood that cancer tends to run in certain families. He noted that with breast cancer, and really that's been understood for a long time. But really, it's only been in the last 50 years or so that we've understood why that is. And one of the key players in this was Mary Claire King. She's a really fascinating scientist and physician, and I'd encourage you to listen to her story that she told on the podcast The Moth. It's really interesting. There's a lot of kind of fascinating little anecdotes that she's had in her life and people that she's met, and talks a lot about the challenges of being both a mother and a world-class researcher. But her story really starts in the 70s. She kind of started off with a bang. Her PhD thesis at Berkeley was on the shared amino acid sequence between chimpanzees and humans. And her thesis was published on the cover of Science magazine. So as a current fellow who's working on a thesis, I definitely appreciate that that is outside of the norm to have that sort of notoriety. But she went on to work a lot with, actually with geneticists, and to work with what was at that point, what we would call now genetic counselors, to study families in which there were hereditary breast cancer. And she used different techniques to be able to determine which features, which inherited familial features are encoded on certain parts of chromosomes. And ultimately, in 1990, she and her team were able to isolate and localize the BRCA1 mutation on chromosome 17 on the short arm. So she published her findings in 1990, and that really set off kind of a firestorm of research. There was a race to clone the BRCA gene, and this was accomplished in 1994 by Myriad Genetics. And that really kind of spurred a huge amount of optimism. The cover of Time magazine in 1994 declared that there's hope in the war against cancer, and a lot of that was coming out of the work that Mary Claire King was doing. We'll talk a little bit about Henry Lynch and his work with the hereditary non-polyposis cancer syndromes. So really there was a lot of hope that understanding the genetics behind cancer was going to help us cure it. And so that's a little bit of what we'll talk about today. I think it's important to understand mutations in cancers and really understand this point that all cancers are genetic or epigenetic, but not all are hereditary. And so sometimes we'll say, there's a familial, they have a genetic cancer or something like that. We kind of use that a little bit imprecisely, but what we really mean is there are hereditary cancer syndromes and hereditary forms of cancer, but really all cancers come from some sort of a genetic aberration. So when we talk about mutations, we're talking about either germline or somatic mutations that lead to cancer. Germline are inherited, and they predispose to an elevated cancer risk across generations. And these germline mutations are really what underlie hereditary cancer syndromes. Um, and then for somatic mutations, they underlie all tumors, and usually multiple mutations are required, and these can result in or uncontrolled growth. So in this little cartoon on the left here, we see what a germline mutation is represented as this little lightning bolt attacking the gamete. So you have a germline mutation, and so every cell in the woman's body is affected and predisposes her to cancer, which is why so many of these cancer syndromes, there's multiple cancers involved, not just a single type. And then somatic, of course, we have an individual cell or cell population that's affected. So when we talk about categories of human mutations, there's single base pair substitutions, and then different flavors of that. There's deletions and insertions, duplications, and inversions, and then expansions or contractions of repeats. We'll talk about that here in a little bit more specifically. What that actually looks like when we're talking about like a cartoon of a strand of DNA, we have our point mutations or deletions in coding sequences. So in the top part of this cartoon, you see the deletion actually in the exon, or the affected part of the DNA is in the exon, so the protein coding regions. Sometimes you'll have point mutations or deletions in regulatory sequences. So that little L-shaped arrow is representing the promoter on a strand of DNA. So upstream of that, sometimes you'll have mutations that can either cause overexpression or underexpression based on whether that gene gets turned on or off. Those are the two main types of modifications and mutations we're going to talk about today. We'll talk a little bit about epigenetic mutations with methylation as well, promoter methylation, but those would be the primary two. There's other what's like chromosomal translocations that we kind of think of famously with CML, the Philadelphia chromosome, viral integration, so mutagenesis by insertion of the viral genome, of course HPV causing cervical cancer being a classic GYN example of that. And then gene amplification we'll talk about as well, but you can think about this as kind of an increased gene dose and an increase in protein production. So this is something we'll see frequently with oncogenes. So speaking of oncogenes, there are really kind of two categories of main types of cancer genes. So we think about the oncogenes and the tumor suppressor genes. The more we understand about cancer and cancer genetics, things don't always fit neatly into these categories. So I'm thinking specifically of like P53, which we'll talk a lot about today. You know, P53 is the guardian of the genome. It's implicated in about 50% of cancers, and we think about it, primarily as a tumor suppressor gene, but it's such the protein products of P53 are so varied in their action that really it's a little bit more complicated than that. And there's pretty good research now showing that P53 can act in some ways like an oncogene as well. But today we're going to just talk about sort of the classic oncogene and tumor suppressor genes primarily. So an oncogene is a mutated gene whose protein product is produced in a higher quantity or whose altered product has increased activity. So for you gearheads out there, you can think about it as either a stuck gas pedal or almost like removing the governor, so the thing that slows down the car or kind of gives you a top speed on a go-kart or whatever. If you remove that, there is no suppression of that. So this is a gain of function mutation. So this is a gene and a protein that normally promotes growth, promotes differentiation, or promotes um, cell growth. And so there's a gain of function to where that gets turned on in a more robust way. The mutation is usually at one allele. It produces the effect at one allele, so that's what's shown here on the left side of this cartoon. You really only need one mutation to lead to a defective gene product. These are not typically hereditary, and we'll talk about one exception to that, but not typically hereditary. And also not kind of famously involved with GYN cancers. Now, the HER2 gene obviously described in breast cancer initially, but HER2 is a oncogene. It is involved with GYN cancers as well, such as serous endometrial cancers. And we'll talk a little bit more about HER2 in a second. The RAS oncogene is also kind of widely involved in many different cancers. The MYC gene, the SRC is interesting because it was the first oncogene that was discovered, and it was initially called the Ralph sarcoma virus. There was a thought that it was actually a virally caused or virally affected predisposition to cancer, and this was really thought really all the way up until the 70s. But it was finally discovered that the virus kind of ancestrally had picked up an oncogene from a mammalian species before and was just transfecting that oncogene. So really the virus became the vector for it, not the cause. And then there's the RET oncogene, and this is actually one of the rare ones that's associated with hereditary syndrome. So multiple endocrine neoplasia 2 is associated with a mutation in the RET oncogene. Here is a table that goes through some of the more well-known oncogenes and discusses what their function is. So you can see a lot of these are going to be growth factors or growth factor receptors, protein kinases, which generally turn things on, and then some with transcription factors, which activate genes, and then obviously membrane proteins and signaling and those sort of things. Specifically talking about the HER2/neu oncogene, so it's in the epidermal growth factor receptor tyrosine kinase family. And HER2/neu is interesting. It's a co-receptor, so it doesn't really bind a specific ligand, but rather it dimerizes with other EGF receptors to cause downstream effects. And so it does it through this PI3K pathway, but also with the MAP kinase pathway, mTOR, some of these other proteins and pathways that we probably learned back in medical school that promote cell growth and migration, adhesion, differentiation, all those sort of things that can lead to a predisposition to cancer. So just to give a little bit of a GYN oncology tie-in to this, trastuzumab, which is also called Herceptin, which is a monoclonal antibody that binds to and kind of inactivates the HER2 receptor, has been used recently to treat serous carcinomas of the endometrium with some effect. Next, we'll talk about tumor suppressor genes, and these are going to be more of the gene types that we discussed today because these are more associated with hereditary cancer syndromes. So whereas an oncogene or a proto-oncogene is a gene that's turned on and promotes growth, a tumor suppressor gene's normal function is to suppress growth, but it is turned off. So it's a loss of function, and in that case, the tumor suppressor gene can't do its job. It's an aptly named gene family, thankfully. So in this case, it's not like so much a stuck gas pedal or a removal of the governor. It's more like you have your brakes and your brakes go out. So this is kind of a apt analogy too, because if you think about brakes, I don't know if brakes are on all four wheels. I think they probably are, but pretend your brakes are only on two wheels, right? So if you have one brake that goes out, you can still you can still stop the car with the other working brake. But if you don't have if both brakes go out, you have an inability to stop the car. So this is sort of our way of thinking about how tumor suppressor genes need a loss of both alleles in order to see their effect. It's more complicated than that. We'll talk about that in a second, but that's sort of a basic understanding. So there are a lot of very familiar genes in this category. So the BRCA1 and 2 mutations are in this category of affected tumor suppressor genes. We talked a little bit about p53 being a little more complicated, but TP53 is classically described as a tumor suppressor gene. Retinoblastoma, APC, neurofibromatosis. P10 is a really common one with endometrial cancers, as well as these next four genes, the MLH1, MSH2, MSH6, and PMS2. These are all the mismatch repair genes that are associated with hereditary GYN cancer. This is a little bit more of a comprehensive list, and just for test-taking purposes, the reason I included this was that it includes the chromosomal location. For those of you taking creogs or even your shelf exams, I've seen these before for some of the more common genes. So understanding that p53 is on chromosome 17, I think, is important. Understanding that where the BRCA mutations are, I think, is important as well. Also on 17, thankfully. So we talked about tumor suppressor genes often being hereditary, but they certainly aren't always. So there are both spontaneous and hereditary versions of cancers caused by these tumor suppressor genes. P10 is a good example of this, so that it can be acquired, and in fact, over half of type 1 endometrial cancers demonstrated P10 mutation, and the vast majority of these are spontaneous. But it can also be hereditary. So Cowden syndrome, we'll talk about in a little bit, autosomal dominant syndrome with a hereditary mutation in the P10 gene. Again, if it's spontaneous, it's typically going to cause one type of a cancer, whereas if it's a hereditary loss of one allele, that typically does predispose you to multiple different types of cancer, and that's why we see these cancer syndromes. The retinoblastoma gene is another example of something that could be both acquired or hereditary. So in its familial form, one germline mutation is inherited and a second somatic mutation is acquired. In its sporadic form, both mutations are acquired. So the sporadic cases, this is thankfully kind of from a epidemiologic standpoint and really just sort of a biologic math standpoint, this gave a lot of information to help develop Knutson's hypothesis, particularly with the unilateral versus bilateral optic tumors. So Knutson's two-hit hypothesis, so this is Alfred Knudsen here down in the corner. This was first proposed back in 1971 when he was a researcher at the UT Health Science Center in Houston. And essentially he kind of took a statistical approach to arriving at this conclusion. Of course, DNA had been discovered in 1950 by Watson and Crick, and there was a lot of, obviously kind of a flurry of scientific discovery in the 60s and 70s. But he really kind of arrived at this more from a statistical approach about the two-hit hypothesis, basically causing the loss of both alleles to cause cancer in a sporadic cancer versus hereditary cancer, where you are born with a mutation in one of the two alleles and acquire the second. So as I mentioned before, it is a little more complex than this. He described the two-hit hypothesis in retinoblastoma, which is kind of your classic gene for this, and it does hold well. So these sort of gray gradient bars are actually expression level of the protein. So this isn't just the allele, but this is the protein products. And then on the right, you can kind of see the phenotype. So in order to get cancer with retinoblastoma, you have to have zero expression, essentially. But that's not the same with all of these tumor suppressor genes. So for instance, p53 exhibits this phenomenon called haploinsufficiency. And in this case, you can start to increase your risk for cancer with the loss of just one allele. And then obviously with the loss of a second allele, you're much higher risk of cancer. This is in kind of a dosed population of protein, and obviously there are a lot of reasons that a gene can be turned on or off. So you have to think about this more in a population of cancer cells or a population of potential cancer cells, not necessarily in a single cell, in order to understand these gradients better. P10 exhibits a couple of really interesting phenomena. So there's this quasi-sufficiency where there's an increase in cancer risk if only 80% of the normal phenotype is shown. Obviously that increases, but there's this sort of inflection point where once enough of the gene product is mutated, there's this P10 loss-induced cellular senescence feature, which essentially signals the rest of the body that there's an issue with the production of this gene product, and signals apoptosis and basically kind of shuts down and sort of brings along these fail-safe mechanisms in order to recover. So if you have zero expression of the P10 gene, your cancer risk is actually lower than if you have basically a smaller amount of expression. So hopefully that's clear. If you guys want to read more on this Berger paper in 2011 is a good one. Also was co-authored with Knudsen. So for instance, like P10 is actually a phosphatase. So, this is just a chart for us to review what we talked a little bit about today as far as oncogenes and tumor suppressor genes. This is, again, simplified. It doesn't really talk about the haploinsufficiency issue, but I think that is important to understand. And the bottom line is there's just this really delicate balance between your tumor suppressor genes and your oncogenes, and cancer predisposition really is, in many ways, about balance. Okay, so let's get into some of the specific cancer syndromes. So we'll talk first about hereditary breast and ovarian cancer syndrome, which is the most famous of these syndromes. I'll mention a little bit on hereditary ovarian cancer syndrome, and these are the non-BRCA associated genes that are still associated with homologous recombination defects. So hereditary breast and ovarian cancer syndrome contributes to about 10% of implicated cancers, and about 18% of ovarian cancers are hereditary breast ovarian cancer, so BRCA1 or 2, whereas only about 6% are somatic BRCA1 or 2 mutations. So that's important. We talked earlier about how genes can be either, mutations can be inherited or acquired. We think of BRCA1 as being inherited, but just be aware that up to 6% of these ovarian cancers with BRCA mutations, those mutations are somatic. So that becomes important, especially with the newer PARP therapies and some of the newer trials like SOLO1 showing benefit for both somatic and inherited forms of BRCA mutations. we talk about BRCA1 and 2 together, like they're, you know, two halves of the same coin. They're really not at all homologous. They are part of a bigger pathway, which I'll show you here in a second, but really they aren't anything alike. Um, the prevalence of BRCA mutations depends a lot on the ethnic and racial background of your patients. So for African Americans, for instance, BRCA 1 is about 1% of the population, whereas BRCA2 is about 3%. But if you look at the Ashkenazi Jewish population, it's up to 10% have a BRCA1 mutation, as compared to like 2 to 3% of the white non-Ashkenazi Jewish population. Talking a little bit more about the specific differences between BRCA1 and BRCA2. They're found on different chromosomes. They're different sizes. BRCA1 is about half the size of BRCA2. Now, the average protein in the human body has about 500, or the average protein product has about 500 amino acids. So if you divide this by 3, you can see that BRCA1 is at least 3 times bigger than your average protein. BRCA2 is at least 6 or 7 times bigger. So these are big proteins. This is kind of a picture of what BRCA1 looks like. BRCA2 is way more complicated. I didn't include it. The mutations and the kind of conformational changes that come from these mutations are different. There's at least 6 different isoforms of BRCA1. So when we're talking about these mutations, we kind of simplify it for discussion purposes, but you just need to understand that they're a little more complicated than that. And this is where BRCA1, BRCA2, and then also some of the other proteins that we'll discuss when we talk about hereditary ovarian cancer, how they play into this whole pathway of what we call homologous recombination defect repair. So when you have a double-strand break, you basically have a protein complex that helps to sense that double-strand break. You have mediator complexes that help essentially to resect the kind of the aberrant nucleosides, and then you have the strand invasion and homologous repair that happens with these effector complexes. So there's quite a lot of different protein interactions that go into homologous recombination, but phenotypically, that's why we see a similar phenotype, similar predisposition to cancer, even though there may be several different genes that can be the reason for that. When we talk about risk of certain cancer types for BRCA1 and BRCA2, they do differ a little bit, and that's because, as I said, there are different proteins and they affect the homologous recombination deficiency pathway differently. Most famously, breast cancer is up to 80%. We say in BRCA1. Maybe a little bit less in BRCA2, but definitely breast cancer being the most common in both of those. For ovarian cancer, you can kind of remember it as being like a 40-20 split, so 40% for BRCA1, 20% for BRCA2, although there's some variations. We talked a little bit about, depends on what population you're talking about, but these are lifetime risks for cancer. And then the other associated cancers, so male breast cancer and prostate, obviously in men, but pancreatic melanomas as well can be issues with BRCA. The question has come up before, is there an increased risk of endometrial cancer with BRCA1? And there isn't an increased risk overall, but it does seem that there's a slight increased risk of serous endometrial cancers over the lifetime. So the lifetime risk is somewhere around 3 to 4.7% is what I've seen. So there's a discussion with this because BRCA patients, will talk a little bit about what we do as far as risk reduction for them. But the question is whether or not you would do a hysterectomy as part of the risk-reducing surgery. So the NCCN, which is sort of our main guidelines for how we manage cancer patients in the United States, they state that the provider patient should discuss the risk and benefits of concurrent hysterectomy at the time of risk-reducing salpingo-oophorectomy, but it's not mandated. I think a lot of patients do elect to have this done because of this potential risk of endometrial cancer. It also, in some ways, can simplify your treatment of breast cancer as well, because you don't have to worry about the endometrial hyperplasia as much. Although if you're taking the ovaries out, tamoxifen is not used as much anyway. It's a little bit off topic. Okay, so we talked about the hereditary breast and ovarian cancer syndromes, but now I'm going to focus just on the hereditary ovarian cancer syndromes. And if we remember this pathway we discussed briefly, there are lots of other proteins that are involved in this pathway, and mutations in some of these proteins do predispose patients to ovarian cancer. And so it's the RAD51C, RAD51D, and BRIP1 are the ones that really kind of would be a high enough risk to where we would consider a risk-reducing salpingo-oophorectomy, usually at age 45 to 50. These others, and this list gets longer and longer every day, there's just not enough information on whether or not to recommend. So these are kind of moderate risks. About 2.5% of ovarian cancers are from this hereditary ovarian cancer syndrome. We remember from one of the first slides, about 18 or so percent are from BRCA1 or 2 mutations. So much less is due to these other mutations, but I think we're learning more and more about these. Again, that variable penetrance of these other gene products is what what makes them a little bit harder to predict as far as what cancer risk for your individual patient is. So screening is really important. Well, not screening, but risk reduction, and also genetic testing is important. I wanted to talk just a brief bit about what's kind of been referred to as the Angelina effect. So in May of 2013, Angelina Jolie wrote an op-ed in the New York Times that talked about her genetic predisposition to BRCA and her decision to undergo prophylactic mastectomies and other prophylactic surgeries. Just to kind of get a sense of what that did in the population, over the next 2 weeks, there was an immediate 59% increase in BRCA1 or in BRCA testing, and resulted in about 4,500 tests above baseline. And actually, even 4 years out, genetic testing was up by about a third. And thankfully, this didn't increase the risk of unnecessary prophylactic surgeries or anything like that, but there was a really big increase in testing, and unfortunately, probably a lot of this was unindicated testing. So when we talk about these sort of situations, the screening and the testing for these mutations is complicated and should be done using guidelines, not using kind of your amygdala. There are guidelines, so the NCCN has genetic counseling and testing guidelines, and a lot of these are going to be based on either personal history, so what actually your personal history of cancer and what type of cancer you have. What I would point out on this slide is epithelial ovarian cancer. Anybody with an epithelial ovarian cancer should have genetic counseling and likely testing. The family history, there's a couple different ways to do this. So either, if you've had an affected family member, or obviously a family member who's tested positive for BRCA, or an affected family member by one of these cancers. And then the other ones that should be tested have to do with a probability score. There's a few different ones. This BRCA Pro is one that I've used before, but these basically, you plug in factors and it kind of spits out your risk score. So if your risk score of being BRCA positive is above like a 5%, the NCCN would recommend genetic counseling for those patients. So there are guidelines. Again, it's cancer, it's age of diagnosis that plays into this, obviously some family history as well. So how do we actually do the genetic testing for our patients with epithelial ovarian cancer? So again, NCC guidelines and really best practice is that these patients get germline testing at the time of initial diagnosis. This has become more important recently because of the results of the SOLO-1 trial. So this was published in 2018. It showed a 70% reduction in progression-free survival for BRCA1 and 2 patients in the maintenance setting. So these are patients who've completed their cytotoxic chemotherapy and then go on to have an oral, what we would call a PARP inhibitor, which is a specific treatment that seems to work best in patients with homologous recombination defects. This led to the FDA approval for olaparib maintenance and advanced ovarian cancer, really in the upfront setting, which is kind of a big deal. We used it longer in the recurrent setting, but it's now being used in the upfront setting. So getting this testing early on and having that back by the time the patient ends their cytotoxic chemotherapy so they can start their PARP inhibitor is important. So if they're positive for BRCA1 or 2 or any of these other variants, you can either go on to do an expanded panel, or I think a lot of us are starting with the expanded panels now. If they're negative, it's important to do somatic tumor testing. So this can be done with IHC, or there's other expanded panels that you can do on the actual tumor as well. So if we remember one of those earlier slides, 18% of BRCA was in ovarian cancer. About 24% of ovarian cancer is BRCA related. 18% of that is hereditary, but about 6% is somatic. And these maintenance therapies with PARP inhibitors can be effective in the somatic, those with somatic mutations as well. So that's why this testing is really so important. So there are certainly challenges to genetic testing in the United States. Those who need it can't get it. So there's access to genetic counselors, which are in rare supply. The cost is going down every year, but it's still an expensive cost out of pocket. Insurance companies generally are pretty good about paying for this, especially for patients who meet criteria by the NCCN guidelines, but that's certainly not available for all of our patients. And then there's the issue of those who don't need it getting it. So the direct-to-consumer marketing, the fact that you can do a 23andMe, you can do a lot of these, tests with just sending in a cheek swab, that does present problems because if it's in a population that has a very, very low prevalence of this mutation, it really affects your positive and negative predictive value of your test, and that can create some long consults. And then what to do, and about the tracking, that can be an issue in a lot of clinics. These tests are done, with the current information now, but every year, the panels are being expanded. Some of these companies like Foundation One and Myriad will continue to follow up and will basically notify patients if they identify a new genetic mutation that's associated with hereditary cancer syndrome. in the future. So there's a lot of follow-up there. Some of that's done directly with the patient, um, but keeping track of these things can be a challenge. One issue is just people are having smaller families. This study was actually done by Mary Claire King's group, but it showed that 50% of BRCA positive women didn't have sufficient number of family members to warrant testing. So that can be an issue. I think that's been identified and it's been tried to be corrected in the testing criteria for BRCA1. So women at higher risk. So for instance, the Eastern European Jewish population, the Ashkenazi Jews, are able to have testing done just by virtue of their ancestry. So I think that's one of the things, to try to help avoid this missing people just based on small numbers of family members to get cancer. And then a big issue is interpretation of variants of uncertain significance, or these VUSs. And this is one of the downsides to doing expanded panel testing, is that you can run into a situation where you, essentially can have up to 40% of patients having these variants that you really don't know what to do with. They're not actionable mutations, but they're things that we have to discuss with patients. So I think that's really important, and the NCCN points this out. Prior to a patient having genetic testing, they need to understand that there's a risk for having these variants of uncertain significance, and they need to understand what to do with that. So that was just sort of an introduction to breast and ovarian cancer syndrome and ovarian cancer syndrome. Hopefully that is helpful for you guys. We're going to go into the hereditary non-polyposis cancer syndromes, or what's called Lynch syndrome, next. This is the mismatch repair gene deficiencies. So again, a little history. This is Henry Lynch of Lynch syndrome fame. And he really built on the work of a physician named Aldred Worthen, who practiced at the University of Michigan for years. This was in the early 1900s. I think it was 1895, he identified this family G, which was a family of a woman who worked at the hospital that he worked at, who had a really extensive family history of colon cancer. And so Worthen went along and did a lot of studies. This is actually one of his original genograms here for this family G, and was able to really, it's become one of the most studied family trees in the world, is this family. Worthen, unfortunately, was not, people are complicated. He was a eugenicist as well, and that was part of his motivation for studying hereditary cancer syndromes. But Lynch was able to build on this family G and kind of continued to study them. He applied for a grant to continue studying them in the 1970s. That actually was denied, but on his own, with his own money, essentially, he studied this family, even arranging family reunions and paying for them, that sort of thing, to get a better sense of the hereditary nature of these colon cancers. Again, kind of in the early 90s, we remember the discovery of BRCA1 was in 1990, and then it was cloned by Myriad Genetics in 1994. In 93, Aaltonen from the University of Helsinki discovered this microsatellite instability marker, MSH2, and discovered that it was located on chromosome 2p. Really within a few months, there was a group from University of California, San Diego, that discovered MLH1 on the third chromosome. So really there was this flurry of discovery, and this is the other part that went into this big Times headline, or Time Magazine headline rather, talking about hope in the war against cancer. So what is Lynch syndrome, and what are the cancer types associated with it? So colon cancer is obviously the most common, and this is talking about lifetime risk. both with the BRCA and Lynch syndrome, I tried to include the general population risk. I think that's just helpful to sort of know for comparison. Um, but colon cancer is the most common, certainly endometrial, stomach, ovary. You can see the risks there. They do vary a little bit based on whether or not the mutation is in the MLH1 or the MSH2 proteins, and we'll talk a little bit about why that is. But lots of different cancer types with Lynch syndrome. Just a little bit of a different picture about where those are in the body and kind of the extracolonic malignancies. So particularly thinking about the lifetime risk by the age of 70 of endometrial cancers up to 60%, and ovarian cancers about 12%. I think this is one of the most important slides. This is why I made it its own title slide. But 50% of women with Lynch will present with a gynecologic cancer as their sentinel cancer. This was a paper done by Karen Liu at MD Anderson, really published a while ago now. But I think this is important as a GYN oncologist, as gynecologist, to understand this, that that we will either see these patients with usually endometrial cancer, but ovarian cancer can also precede the colon cancer syndrome. So as I mentioned before, most of these are due to hereditary germline mutations in MLH1 and MSH2. And this graph is actually for all Lynch, not just specific to endometrial or to ovarian cancer. So what is the main defect in Lynch syndrome? So it's really this deficient mismatch repair and microsatellite instability. So I'll try to explain this a little bit, hopefully make some sense of it. So microsatellite instability is caused by defective mismatch repair. And these mismatch repair genes for Lynch syndrome are MLH1, MSH2, MSH6, and PMS2. We can detect these by immunohistochemistry, so these can be detected at the time of either endometrial biopsy or the final pathology of a hysterectomy specimen or ovarian cancer as well. So microsatellite instability is either the expansion or reduction of the length of repetitive DNA sequences in tumor DNA, and this is detected by a special PCR test. So what we consider MSI high is 2 or greater mutated sequences, and this is really most of what we see with Lynch syndrome. MSI low is 1 mutated sequence, and then MSS or microsatellite stable is no mutations. So for Lynch, what this looks like, you have this little dimer essentially of MSH2 and MSH6 that sort of connect together. They, like I said, they dimerize, they recognize single nucleotide mispairs, and they bind to DNA kind of like this sliding clamp. They call their little buddies MLH1 and PMS2, which are kind of like these Mickey Mouse ears that essentially come and bind to the dimer on the DNA. And this MLH1 complex is basically a guide for an exonuclease that comes in and snips out the mismatch repair or the mismatch on the DNA and repairs it with the resynthesis of the normal DNA and normal base pairing. So we can test for deficient MMR. I mentioned IHC. It's just you need to be aware of how to interpret it. So because of the way they dimerize, if you lose protein expression of like PMS2, then you have to know how to interpret that. Whereas, if you have an MLH1 loss, you're actually going to see both MLH1 and PMS2 not staining on your IHC. So the pathologists are aware of this, but just to know that it's, all these tests, it's never like, you push a button and it's, you get a result. You have to know how to interpret the result. Just one kind of interesting, so there's some unique things that pathologists can see. So for colon cancer, there's some really unique features of colon cancer that will tip a pathologist off that they might be looking at a MSI. So things like tumor infiltrating lymphocytes and things like that. Those are a little bit less specific in endometrial and ovarian cancer, but there are some things that can tip pathologists off as to what they might be seeing, or if it could be due to a mismatch repair defect. One thing that I think is really interesting, so a lower uterine segment in endometrial cancer is actually pretty rare. It's just like 1 or 2% of cancers. But in this large case series by Shannon Weston and her group at MD Anderson, they showed that 29% of lower uterine cancers were due to Lynch syndrome. I think this is kind of unique. I don't know that we really know why that is, but it's a kind of a unique association. So MSI testing, so we talked about how MSI is caused by deficient mismatch repair. And there's actually, that's not the only way to end up with microsatellite instability, but with what we're talking about today with Lynch syndrome, that's germane to this talk. It isn't routinely done for our GYN cancers, but it can be done. And if it's done by this PCR with capillary electrophoresis. What you end up with is these little spikes. So these are what we call the relative fluorescence unit. So this is the RFUs, and then this is your base pairs. So there's these NCI-approved loci that we can test. So BAT25 is one of them, for instance. So this is a kind of a specific region that you look at. So for instance, one of the things about MSI testing is you have to submit some normal tissue as well as tumor testing. So in this case, you have normal tissue that has like 7 peaks, which represents this region with these 7 different repeats, whereas in the tumor there's 10 peaks right here. So that would be MSI greater than 2, so this would be considered MSI high. Just so you know kind of how that's done. So how do we diagnose Lynch syndrome? So there was this traditional criteria, that what's called the Amsterdam criteria, and this was developed back in 1990, so this is pretty old now. And this was a completely family history based approach, and this kind of came up with the famous 3-2-1 rule, which you guys probably saw in like first aid for step 1. But basically, you have 3 affected family members in 2 generations and at least 1 under the age of 50. And that can get you, that's your criteria for being able to diagnose a Lynch syndrome based on these traditional criteria. So it was really specific, but really not very sensitive at all. So you were missing a lot of people. So if you look at different approaches to how to test, the Amsterdam and Bethesda were kind of based on family history, but then once you start including the mismatch repair, IHC, your positive predictive value gets a lot better, and your percentage of the mutation carriers that fulfill the criteria is actually a lot better as well. So you see, there's not a terrific improvement when you add this MLH1 methylation status, but it does improve the cost effectiveness, and we'll talk about what that is here in a second. For all of for these, the negative predictive value was pretty good, but it's just a matter of you don't want a test to be. It's great if a test is specific, but you also want it to be sensitive. So these are the new genetic testing guidelines, and they do have a component of it that is family history based, a component of it that is personal history based, but then there's also a pathology component as well to people who get the germline testing. The SGO and The NCCN both agree on universal testing of endometrial tumors for the MMR gene. So this can be done either through IHC or through a gene panel. Most of us do this through IHC. There is a kind of a workflow or algorithm for this, and this starts differently than it does with ovarian cancer. So if you think about ovarian cancer, once you have that diagnosis, you do your germline testing. But with uterine cancer, and this is specifically uterine, you start off with your somatic tumor testing, and that can, like I said, be done with IHC pretty quickly, cheaply, easily. If you show a loss of some of these proteins, then you would need to go on and identify which ones were lost. If you lost MLH1 plus or minus that other part of the dimer, PMS2, you would actually go on to methylation testing. So we talked a little bit about epigenetic modifications. Methylation of a promoter is really the most common one that we see in cancer. And your methylation status can help determine whether or not this loss of MLH1 is due to a hereditary cancer syndrome or acquired. So by definition, we don't inherit epigenetic changes, right? So that's the way to think about, if you have a methylated promoter of MLH1, then which is a PCR test, then that cancer is likely not a genetic cancer. There I went. All cancers are genetic, not a hereditary cancer, and you would need to proceed with germline testing. If there isn't, if your promoter isn't hypermethylated, then you would go on with germline testing for the patient to determine whether or not they had a Lynch syndrome or not. So how to manage? This is the NCCN guidelines. It's pretty busy, so I'm going to give you a little easier way to look at this. And we don't know a lot as far as what the best optimal way to manage the risk of endometrial and ovarian cancer in Lynch syndrome. So there isn't any evidence that endometrial biopsies save lives, but we can consider these every 1 to 2 years. No evidence for transvaginal screening, but may consider this in a postmenopausal woman. And then also a risk-reducing hysterectomy. We don't know that it improves mortality, but it is an option. And I think a lot of people do like to do this because the risk is so high, up to 60%. One thing that's very different about endometrial cancer as compared to ovarian, though, is endometrial almost always presents with symptoms of abnormal bleeding, and especially in somebody who has a genetic predisposition to that. It's more of a discussion than, for instance, the risk-reducing salpingo-oophorectomy that we recommend for BRCA. For risk-reducing salpingo-oophorectomy for Lynch, we recommend that they complete it, or that they have that done when they completed childbearing, at least for the MLH1 and MSH2 mutations. Right now, there's insufficient evidence for the other two. EpCAM, we didn't talk too much about that, but that's another Lynch-associated mutation. It's phenotypically like MSH2. So even though the NCCN guidelines aren't explicit about this, I think a lot of us would just manage these similarly. You could consider transvaginal ultrasound and CA-125 surveillance, but there just isn't great data for that. So I'll briefly touch on these last 3 syndromes. Really the bulk of what you need to know is the first 3 syndromes that we spoke about, but you might get a question or two about Cowden, Peutz-Jeghers, and Li-Fraumeni syndrome, so we'll talk about those. So Cowden syndrome, this is a hereditary P10 mutation in an autosomal dominant fashion. The patients end up with multiple hamartomas. You can get this oral mucosal papillomatosis, and then there's trichomonas, which are benign follicular tumors of the outer root sheath that are pretty characteristic for Cowden syndrome as well. These patients do have a lifetime increased risk of endometrial cancer, and risk for breast cancer as well, as far as kind of GYN-related cancers. There isn't really, the screening guidelines for this from the NIH are, again, not super evidence-based, but probably reasonable as far as mitigating the risk of breast and endometrial cancers. As far as testing for Cowden syndrome or who should get genetic testing, I would just know that there's a lot of, based on physical exam findings or patients on autism spectrum disorder. There's macrocephaly that's involved as well. So there's, different features that would prompt genetic testing. Obviously, this is something rare enough to where if you have a suspicion, if you have a patient who has these multiple hamartomas, this is something that you can reference, which is the NCCN guidelines. For Peutz-Jeghers syndrome, this is a mutation of the STK11 gene. I've seen this on the Creogs, by the way, which may not be a fair question, but it is on there. This is autosomal dominant. The really characteristic thing for this is these mucocutaneous melanin pigmentation spots, typically, most notably on the lips, but certainly you can see vaginally as well, as far as what you'd see on your GYN exams. They do have an increased risk of uterine, breast, GI, and colon cancers, and the cumulative cancer risk is high at 76% by age 70. One really interesting thing about Peutz-Jeghers, there's two kind of unusual GYN cancers. I did mention there's uterine cancer as well. About 9% will get a uterine cancer. But there's two kind of pathognomonic unusual ones. One are this scatat tumors, or these sex cord tumors with annular tubules. 20% of patients with Peutz-Jeghers will get this. This is kind of a histologic look at this. These are just really unusual ovarian tumors. And then your adenoma malignum of the cervix. This is a adenocarcinoma, really, really aggressive tumor that you'll see in 10%. And it's really uncommon to see this outside of Peutz-Jeghers. So certainly if you have a patient with this diagnosis, that would prompt a workup if it wasn't already done based on their melanin pigmentation. As far as cancer risk and surveillance guidelines, just be aware again there's NCCN guidelines for this as well. They don't typically recommend a prophylactic BSO or anything like that, although that's something that could be discussed. One other thing I meant to mention about the scatat tumors, if I can go back, that's not going to let me, is that they are associated with hyperestrogenism, so you'll see that sometimes they can tend to act like a Sertoli tumor, so you can see increased estrogen, precocious puberty, that sort of thing. All right, so for Li-Fraumeni syndrome, this will be the last thing we'll talk about today. This is a mutation in the guardian of the genome, so the TP53. It's highly penetrant, almost 100% risk of cancer by age 70. Breast is the most common, but you have these sort of characteristic tumors as well, osteosarcomas and soft tissue sarcomas, your brain, adrenal leukemias. There's an increased risk of ovarian and endometrial cancer, but really kind of the incidence isn't super clear. GYN cancers aren't specifically addressed in the NCCN guidelines, so that's something just to be aware of. This is just a review slide of the different syndromes that we spoke about today, and the cancer risk by site, something you guys can look at. Pause the video here if you want to look at it. And then just a review of our objectives. Hopefully we met these today. As far as resources go, the SGO Genetics Toolkit I think is helpful. It goes through about 7 different cases, and certainly a good exam review beforehand. Pearls of Excellence are always great. 2 other resources for you. Howardisms is a fantastic resource for OBGYNs. Howard Harrell was a ETSU professor, now is in private practice, who just has a really great view, really kind of an understanding of probability based medicine. He writes a lot about cognitive bias and that sort of thing in research, but a lot of what I know about screening and screening tests and what make a good screening test learned through studying the things that he's written. And then if you're interested in OBGYN medical history, I tweet at Save the Eponyms, and I'm not super active, but one every week or so, just to kind of anchor us. I think sometimes we have a little bit of an arrogance that we, that we understand things better than people did in the past, and I don't know that that's always as true as we'd like it to be. So, thank you guys for your attention today. I am happy if you guys would leave some comments. That's great. If you have any specific comments, or questions, I can answer those in the comments as well, and share this if you thought it was helpful. Thanks.